Assalamualaikum and a very good morning to all faculty members. Okay, thank you for tuning in and welcome to another webinar series of Breakfast at UMHealth. I'll be your moderator for the first session. My name is Azwani Abdullah and I am a clinical microbiologist from the Department of Medical Microbiology, Faculty of Medicine, UM. So just a brief introduction for our first topic. The genus Mycobacterium includes several pathogenic species, including members of the Mycobacterium tuberculosis complex or MTBC, and also non-tuberculous Mycobacterium (NTM). And to date, there are several methods that can be used to detect mycobacteria from the clinical samples, including smear microscopy, culture, and also molecular techniques. But the question is, in a world racing toward high-end molecular diagnostic, could a rather simple fluorescent dye, for example, this Auramine O, still outshine and proves its value in the fight against mycobacterial infections? So to enlighten us further on this topic, it is an absolute honor and pleasure to welcome our first speaker for today, Associate Professor Dr. Nadia Atiya. So Prof. Nadia Atiya is currently an Associate Professor of Medical Microbiology at the Faculty of Medicine, UM, and a consultant clinical microbiologist, as well as the head of the Department of Medical Microbiology, UMMC. She also serves as the co-coordinator of the Diagnostic Mycobacteriology Unit and the Deputy Chairman of the Tuberculosis Committee at UMMC. So she has received multiple awards and recognition for her dedicated work related to diagnostic and research in mycobacterial infections, both nationally and internationally. So she is undoubtedly an expert in this field to speak to us today. So without further ado, please join me in welcoming Associate Professor Dr. Nadia Atiya with her topic, Diagnostic Utility of Auramine O Smear Microscopy for Detecting Non-tuberculous Mycobacteria versus Mycobacterium tuberculosis in adult clinical samples. So you may forward any burning questions to Prof. Nadia through the chat box and we will address them at the end of the session. And with that, Prof. Nadia, it's over to you.
Okay, so good morning, everyone. Yes, I think I was muted just now. Apologies for that. Okay, so thank you, Dr. Azwani, for the very kind introduction. So I hope everyone can see my slides. So I'll be presenting the findings from a study that was conducted by my research collaborators and I, and that was recently published in the BMC Infectious Diseases Journal. Okay. So I think Dr. Azwani had mentioned a little bit about what mycobacteria are. Okay, so I'm just going to briefly give a little bit of background information, okay, about mycobacteria. So the genus Mycobacterium encompasses several pathogenic species, okay, including members of the Mycobacterium tuberculosis complex and non-tuberculous mycobacteria. So Mycobacterium tuberculosis complex, or MTBC, is the causative agent of tuberculosis, or TB, which is a leading cause of death worldwide and a major global public health concern, especially in developing countries such as Malaysia. Now, while MTBC is the most prominent pathogenic mycobacterial species, as it is the caustic agent of TB, most of the species within the genus Mycobacterium are actually non-tuberculous mycobacteria, or NTM. So NTM are, they can be commonly found in the environment, especially soil and water. So they are largely considered contaminants or colonizers when isolated from clinical samples. However, clinically significant NTM infections appear to be increasing worldwide, especially pulmonary disease. So there are several methods that can be used to detect mycobacteria from clinical samples. So mycobacterial culture...
Sorry, Prof.
Yes?
Prof. Nadia, sorry, can you full screen your slides?
Okay, so I was saying that mycobacterial culture is considered the reference standard method for detection of mycobacteria, as it provides a definite diagnosis of TB or NTM disease. However, the culture method is very time consuming. Okay. However, the culture method is extremely time consuming. It's resource intensive. It is very labor intensive, actually. It requires up to 8 weeks for the final identification of mycobacteria. Now, AFB smear microscopy, so acid-fast bacilli smear microscopy, remains the primary and most rapid and inexpensive screening method for mycobacteria, yeah, so including MTBC and NTM. So when we see acid-fast bacilli or AFB in a smear under the microscope, this actually provides a preliminary diagnosis of mycobacterial infection. So these are the steps involved in performing AFB smear microscopy using the Auramine O fluorochrome stain. So it's actually a relatively simple staining method that takes less than 30 minutes to perform. So after we process and concentrate the sample, the clinical sample, 1 to 2 drops of the material are smeared onto the slide. And then we then add the primary stain, Auramine O, which penetrates the cell wall of the organism. And then we add a 0.5% acid alcohol solution to the slide. Now, if the organism is an acid-fast bacillus, such as MTBC or NTM, decolorization with acid alcohol does not remove the Auramine O stain from its cell wall. Okay. We then add potassium permanganate, which acts as a counter stain. So this counter stain will provide a contrasting background so that we can clearly see any acid-fast bacilli that are present. We then view the slide using a fluorescence microscope. Okay, so the test is positive if bright yellowish green fluorescent bacilli are present, and the test is negative if they're absent. So this image here shows a positive Auramine O smear slide, as we can see bright yellowish green fluorescent bacilli. Okay, so AFP smear microscopy using fluorochrome stains like Auramine O is the method recommended by current guidelines, both national and international guidelines for the direct examination of clinical samples for mycobacteria, because fluorochrome stain smears can be examined at lower magnification than other methods, thereby increasing examination speed and sensitivity. So I think that most of you would be more familiar with the Ziehl-Neelsen stain, the ZN stain, yeah. So the Auramine O stain is actually about 10% more sensitive than the Ziehl-Neelsen staining method. So that's why it is the recommended microscopy method for identifying mycobacterium clinical samples. Now, what are the knowledge gaps in this area? Yeah. Now, the few studies that have evaluated the diagnostic utility of fluorochrome smear microscopy using the Auramine O stain for detecting mycobacteria in clinical samples have focused their analysis solely on respiratory / sputum samples. Yeah. So not many studies. Previous studies have actually also analyzed non-respiratory or non-sputum samples when comparing the Auramine O smear microscopy to other methods, especially mycobacterial culture, which is the reference standard. Moreover, to date, no study has comprehensively assessed the diagnostic utility of this method for detecting NTM versus MTBC in clinical samples from an adult population in Asia. So the objective of our study was to investigate the diagnostic utility of Auramine O smear microscopy for detecting NTM versus MTBC in clinical samples from an adult Asian patient population using mycobacterial culture as the reference standard. So this was a retrospective study conducted at the University Mayo Medical Center. We included both sputum and non-sputum samples from adult patients aged 18 and above with suspected mycobacterial infection, so either suspected TB or NTM disease. And all the samples were tested using both Auramine O smear microscopy, which is the index test, and mycobacterial culture as the reference standard test. So we analyzed all samples that were tested between 1st January 2018 and 31st December 2022. So this was a 5-year retrospective analysis. We excluded samples from adult patients that yielded mixed NTM/MTBC in mycobacterial culture. We also excluded mycobacterial cultures that were contaminated with bacteria, as well as samples from the pediatric population. Okay, so samples for inclusion into the study. I'm just so sorry, I think I have skipped that part. So samples for inclusion to the study were retrospectively identified, and microbiological data, including sample type and Auramine O-smear microscopy results were extracted from the Department of Medical Microbiology UMMC laboratory information system. Demographic data, including age, gender, and nationality, were retrieved from patient electronic medical records by the UMMC IPSACID system. So all microbiological procedures, including the Auramine O-smear microscopy test and the mycobacterial culture, were performed at the Diagnostic Medical Microbiology Laboratory, Department of Medical Microbiology, UMMC. So I think most of you would know that we have a biosafety level 3 laboratory within the Department of Medical Microbiology, UMMC. And because of that, we have the capabilities of culturing mycobacteria, especially Mycobacterium tuberculosis complex. So this is an ISO 15189 accredited medical laboratory. So AFP smears were made from the sediments of clinical samples that have been decontaminated when appropriate, and then concentrated by centrifugation, and smear microscopy was then performed using the Auramine O state. So we reported the Auramine O smear microscopy result as either positive or negative. So positive meaning that we saw acid-fast bacilli under the microscope, and if we reported the result as negative, that means that we did not see any acid-fast bacilli under the microscope. And obviously, we performed mycobacterial culture because that was a reference standard test used in the study. And mycobacterial culture was performed on both liquid and solid media as per recommendations by international guidelines on the laboratory diagnosis of TB. So if there was growth in mycobacterial culture, what we did was we performed a real-time PCR assay to determine whether the isolate was an NTM or MTBC. So this real-time PCR assay that we use is the Aniplex NTB/NTM assay. So this is a commercial kit from South Korea. It's a very good PCR assay. So we would then report the mycobacterial culture results as culture positive for MTBC, culture positive for NTM, or culture negative for both MTBC and NTM. So the results of our study, so over the 5-year study period, there were 13,087 samples from adult patients with suspected mycobacterial infections that underwent both Auramine O-smear microscopy and mycobacterial culture, of which 12,016 fulfilled our inclusion criteria and were included in the analysis. Of these 12,016 samples, around 68% were sputum samples, and 19% were positive for mycobacteria. NTM and MTBC showed almost equal prevalence among samples that were culture positive for mycobacteria, so 50.2% and 49.8% respectively. So this table shows the demographic characteristics of the patients that had samples that were culture positive for mycobacteria. So of these patients, slightly more than half were men. Most were aged 40 years or older, and the vast majority were of Malaysian nationality. So we actually observed significant differences in age group, gender, and nationality between adult patients with MTBC and NTM culture positivity. However, we didn't go on to further, investigate this and do further analysis. So this is something that we are thinking of doing in the future. So this table shows the diagnostic utility of Auramine O-smear microscopy for detecting NTM versus MTBC in adult samples. So this the findings from our study. So Auramine O-smear microscopy demonstrated high specificity and negative predictive value, but low sensitivity and positive predictive value for detecting both MTBC and NTM. And not surprisingly, its sensitivity, specificity, PPV, and NPV for detecting NTM were lower than those for MTBC. Now, I would like to highlight that our study included all patients with culture-positive NTM samples, regardless of clinical significance, and we did not investigate the distribution of NTM species in our patient cohort. So we actually have the data for this, but we are actually saving it for another study. Yeah? Okay, so previous studies have shown that patients with NTM colonization or infection with certain NTM species, yeah, particularly the rapidly growing ones like Mycobacterium abscessus, they often have lower bacillary loads and consequently lower smear positivity rates. So it is very possible that among the NTM culture positive cases in our study, there was a higher proportion of patients with colonization rather than true NTM disease, yeah, and a higher proportion of those with rapidly growing mycobacterial isolates compared to slowly growing mycobacteria. So this could possibly explain the much lower sensitivity of Auramine O smear microscopy for detecting NTM compared to MTBC that we found in our study. Okay, so our study has some important limitations to consider. So I think it's important that I highlight these limitations. So first, this was a retrospective single center study, which may have led to selection bias. So our findings may also not necessarily reflect what is happening in Malaysia or regionally. Yeah. So second, we analyzed only the first sample from each anatomical site that yielded a unique mycobacterial species in culture, although we acknowledge that some patients may have had multiple samples from the same site yielding the same species. Yeah. So we did this to kind of exclude duplicates. Yeah. However, this may have contributed to the lower reported sensitivity of Auramine O smear microscopy in our study. Now, third, I really mentioned this. We did not evaluate the clinical significance of the NTM culture positive samples because in my first slide, I did mention that usually when we isolate NTM from clinical samples, they usually represent colonization or contamination. Yeah, so this is something that we have to bear in mind when NTM they're isolated from clinical samples. So we had the data for this, but we did not analyze it for this study. Yeah. So if we had actually assessed the clinical significance of the NTM culture positive samples in our patient cohort, this may have provided insights into the diagnostic utility of Auramine O smear microscopy in detecting NTM causing true disease versus NTM associated with colonization or contamination. So this is something that we will definitely look into, and hopefully we'll be able to publish the results of that study in the future. Okay, so despite these limitations, our study has notable strengths. Yeah, so most importantly, it is the first study to comprehensively evaluate the diagnostic utility of Auramine O smear microscopy for detecting NTM versus MTBC in adult clinical samples, irrespective of sample type. Yeah, because we included both sputum and non-sputum samples, and in an Asian patient population. So most of the previous studies that were conducted in this area were conducted in a mainly European patient population. Now, another key strength of a study, the large sample size, yeah, which met the sample size requirements, and of course, because the sample size was quite large, that contributed to the robustness and reliability of our study's findings. So, what are the main conclusions from our study? So, the diagnostic utility of Auramine O smear microscopy was limited by poor sensitivity and positive predictive value for both NTM and MTBC. The overall diagnostic utility of Auramine O smear microscopy for detecting NTM was lower across all 4 parameters, yeah, sensitivity, specificity, PPV, and NPV than that for MTBC. So what does this mean actually? Yeah, I mean, how does this actually impact the clinical management of patients with suspected mycobacterial disease when you get a positive Auramine O result or a negative Auramine O result? Yeah, so a positive Auramine O smear microscopy result was a much more reliable indicator of the presence of MTBC than of NTM, yeah, whereas a negative result reliably excluded MTBC and to a slightly lesser extent NTM. The substantially higher PPV of Auramine O smell microscopy for detecting MTBC compared to NTM is likely due to the much higher prevalence of TB disease than of true NTM disease in our patient cohort. Yeah. So the implications for patient management. So in settings with a higher burden of TB than NTM disease, so and obviously this would apply to the patient population in not only at UMMC, but I think in Malaysia in general. So if you have a patient with a positive Auramine O smear microscopy result with a clinical history that is suggestive of TB disease, then they should be considered for TB treatment initiation while awaiting mycobacterial culture confirmation. Now, in contrast, if a patient has a negative Auramine O smear microscopy result and the clinical history is not strongly suggestive of TB or is suggestive of NTM disease, then it is recommended that they undergo additional testing using alternative methods, such as rapid molecular assays that can reliably detect and distinguish between MTBC and NTM while awaiting confirmation by mycobacterial culture. Now, with that being said, rapid molecular tests are not, they're not cheap, they can be quite expensive. So their high cost may limit the widespread use of PCR, the widespread use of PCR in resource-limited settings. So there is a need to develop inexpensive screening methods, for the direct detection of mycobacteria that not only offer greater accuracy and reliability than Auramine O smear microscopy, but one that is is affordable, and this is very important for improving the early detection of NTM in clinical samples. Okay, so if anyone is interested in reading the full paper for this study, you can scan the QR code. Okay, so before I conclude my presentation, there are a few people that I would like to thank. So first and foremost, I would like to thank Dr. Ong Leong Tong. So he was my Master of Medical Science student who worked diligently on this study and collected all the data. I would also like to extend my appreciation to his co-supervisors and my collaborators on this project. So Dr. Azwani Abdullah from my department, who's also the moderator for my talk this morning, Dr. Do Tianqi from the Department of Medicine, FOM and UMMC, and Prof. Wong Chi Kwan, also from the Department of Medicine, FOM and UMMC, for their invaluable input and expertise, without which this study would not have been possible. Lastly, I would like to thank the medical laboratory technologists of the Diagnostic Microbacteriology unit, are also part of the Biosafety Level 3 team, the BSL3 team at the Department of Medical Microbiology UMMC for their technical expertise in mycobacterial identification testing. So thank you very much for listening and for your kind attention.
Thank you. Thank you so much, Prof. Nadia, for that very insightful presentation. So I believe that would give us more clarity on the value of the Auramine O. I suppose the list talking about stain, because usually we would talk about zilnicin whenever we talk about mycobacterial infections and tuberculosis. So it's more common to hear about zilnicin stain and acid fast bacilla, but not so for Auramine O. So I think this is a very good insight on the role of this special fluorochrome stain. So let me see if there's any questions from the audience. You can put your questions in the chat box. Okay, so at the moment, while waiting for any further questions, do you mind, Prof? I have a few questions to ask regarding your presentation. So the first one is, how does actually the zilnicin, the more common one, or talking about stain, as compared to the Auramine O in terms of their sensitivity and specificity?
Okay, so the zilnicin stain, the more common one, or talking about stain as compared to the Auramine O in terms of their sensitivity and specificity. Okay, so the zilnicin stain, the more common one, or talking about stain as compared to the Auramine O in terms of their sensitivity and specificity. Okay, so thank you, Dr. Wani, for the question. Yeah, so like I mentioned during my presentation, I think most of you would be more familiar, with the Ziehl-Neelsen stain, the ZN stain. So the Auramine O smear microscopy, Auramine O smear microscopy is actually more sensitive than ZN smear microscopy. So it's about 10 to 20% its sensitivity is about 10 to 20% higher than Ziehl-Neelsen smear microscopy. And this is due to the fluorescence contrast that is used and the ability to quickly scan large areas of a slide that has been stained with Auramine O. However, the Auramine O smear microscopy method actually shows slightly lower specificity than ZN smear microscopy because non-specific fluorescence from debris or other organisms can be mistaken for acid-fast bacilli using the Auramine O stain. However, the specificity of the Auramine O smear microscopy method can actually be improved with trained readers. So if the person who's reading the slide is a trained operator and reads multiple Auramine O slides a day, then this obviously would improve the efficiency of the test.
Okay, Prof. So just to clarify, I think this is important for the rest of the non-microbiology people. So the one that actually we reported out to the clinician is actually the Ziehl-Neelsen stain and not the Auramine O. Is that correct, Prof?
Yes. So I think this is something maybe I should have clarified in my talk. So at the moment, at UMMC, the Department of Medical Microbiology, we actually do a two-step staining method, okay, for mycobacterial identification. So we'd actually do the Auramine O stain first. So if that is the Auramine O smear microscopy first, so if the result for that is positive, we would actually proceed with Ziehl-Neelsen. Yeah. So if Ziehl-Neelsen is positive, then we would actually report the result as acid-fast bacilli seen. Yeah. So that's a two-step staining method that we use. And the reason why we do it that way is because, like I mentioned, Auramine O smear microscopy is more sensitive than Ziehl-Neelsen. So the Auramine O method is used as a screening method, and Ziehl-Neelsen, because it's more specific than Auramine O, that's used as a confirmatory method, right? However, many studies have actually shown that there's actually not much added value of doing confirmatory Ziehl-Neelsen smear microscopy. So we're actually planning to look into this to see if in the future we could actually remove the confirmatory Ziehl-Neelsen step when we actually stain samples to look for mycobacteria. So in the future, we may just do Auramine O alone, and the result would just go out as AFB seen or AFB not seen, just purely based on the Auramine O smear microscopy result.
Right. Okay. Thank you so much, Prof. Do we have time? Probably just a quick one, Prof. Is there any rapid molecular test that can detect and distinguish between tuberculosis, Mycobacterium tuberculosis, and NTM directly from clinical samples?
Yeah, okay. So that's a very good question. So there are a few commercial assays that are designed to detect MTBC versus NTM directly from clinical samples. So usually sputum with faster turnaround time than mycobacterial culture. But the problem with these assays, they're very good, but they typically have lower sensitivity for NTM than for MTBC. Yeah? So I give you an example of a commercial assay that is designed to detect MTBC versus NTM directly from clinical samples. So it's the Seegene Aniplex MTB/NTM real-time detection assay. So this is actually the PCR assay that we're using at UMMC to identify mycobacteria from cultured isolates. But this assay can also be used to detect mycobacteria directly from clinical samples. So it's got very good sensitivity for MTBC, but its sensitivity for NTM is more variable. So this is something that I think if we were to introduce this test for mycobacterial detection directly from clinical samples at UMMC, clinicians would really have to understand that this is a limitation of the assay. Yeah, good sensitivity for MTBC, but sensitivity for NTM would be a little bit more variable. Even though in general the PCR assay would be more sensitive than the Auramine osmium microscopy. So hopefully this is a test that we can introduce in the future. At the moment, if clinicians request for a direct PCR assay for MTBC versus NTM for UMMC patients, we outsource the test. Yeah. So of course, this is not ideal. We would prefer to do it in-house. So we will definitely look into this.
Thank you. Thank you so much for your clarification, Prof. I think in the interest of time, we will need to end our first session here to give you for the second speaker. Thank you again, Prof. Nadia, Atiya, and also for the audience for tuning in. That should conclude our first session for today. And I shall pass the floor to the moderator of the second speaker. Over to you, Professor Kartini. Thank you, everyone.